And we're live. We're back online, Manas.
Yeah.
Um, you, can you see everything, Manas? Is everything visible on your side?
I'm able to see all three of us. Uh, and yes, I'm able to see the message about Roberto.
Okay.
Yeah.
So
You want
you're good
to
for the.
guys on to the backstage?
Are you good for the introduction, Manas?
Yes.
Okay.
So, okay. So Roberto Shimzu is a seasoned business leader with over 20 years of experience across healthcare, insurance, and technology. As a CEO and Chief AI Officer of IntelliDoctor, Roberto co-founded an AI-driven clinical decision support system designed to provide real-time, evidence-based recommendations, significantly improving and enhancing the medical practice. His deep involvement in AI development and integration positions has made him as a key figure and a player in advancing clinical solutions through technologies. I now put the stage to Roberto and see what he has to share today in the session.
Okay, thank you, Manas, for the introduction. Thank you very much, Joaquin, for inviting me for this event. For me, it's a pleasure and honor. So, as today the topic of my presentation, it's about AI, of course, driven to provide clinical decision support systems. But the main topic I think that I'm going to focus on is the focus of responsible AI. Um, um, as Manas introduced, I am the CEO co-founder of IntelliDoctor. We are based in São Paulo, Brazil, and we have been live since February this year. And we have significantly, increased our base to more or less today about 2,500 doctors. Ever since we have been, having the opportunity to have this, pool of doctors that has been testing our product, providing us feedback, and we're continue to evolving. And I would like to share also some of the lessons learned that we have been facing, listening the feedback from these physicians. So the intent, I mean, I will provide the presentation more or less in this structure. I will provide, what is the problem that we're trying to solve in IntelliDoctor, what are the solutions that we've been able to provide so far. I will delve a little bit on the architecture and the challenges we are facing and the current areas of research that we are currently working on, some additional considerations, and then I will share some lessons with you. Okay, so the problem that we are trying to tackle is the problem of information overload in medical practice. I don't know how many doctors are in this audience, but I think, as you can imagine, the medicine knowledge evolves very rapidly. They say that the medical knowledge doubles for every 3.5 years. And to cope with the pace of this, speed of new knowledge, doctors would need to read 20 hours a day to stay up to date, which is humanly impossible. And in addition to that, the task, the job of the doctor nowadays involves a lot of administrative tasks, and all in all of this contributes to to this information overload. So the consequences are that medical errors are still a big issue. It also is causing fatigue in doctors, and every research that nowadays, especially in developed countries, developing and developed countries, a lot of doctors say that they are exhausted, they are burned out. Traditionally, this clinical decision support systems is not a new idea. There's a lot of systems like that over the years, and the aim, the goals of these systems is to encapsulate the medical knowledge from several sources and topics, and provide to the physician at the point of practice key information that helps him to make better decisions apart from this problem of information that we just talked. And before the generative AI, those applications were static, were based on predefined rules. Most of them, guidelines were hard-coded in the applications. The applications were sort of clunky, multiple screens and clicks, and limited adaptability to patient context and the ever-changing medical knowledge. So it was very tough to the physicians to navigate through this systems, especially during the medical consultation. It was okay after hours, but during the medical practice, it was very difficult to do that. So now with the advent of generative AI, most likely, everybody knows the impact of ChatGPT. It provides a lot of good things. One of the good things that it provides is the ability to interact with AI through natural language. For the doctors, less training required, because today he can engage in a conversational a dialogue with the app. It is more context driven, so it's adapted to the patient context. And you can input other kinds of data, such as PDF, results of lab exams and things like that. So it broadened the data interpretation. And it looked like it was a good thing, and it looked like medicals were happy and the problems were solved. But it was not that easy, especially in the healthcare settings. Large language models prove to be not reliable. We have several articles nowadays that showed with a lot of evidence the problem, the challenge of hallucination. And hallucination in a healthcare setting, it's very dangerous because we're dealing with lives. So if you have a wrong information that you use for prescribing a medicine, that can be that can have a very hard consequences. So what we do, us IntelliDoctors, we tackle this problem very early on. We use large language models as a language model itself. We don't use it as an oracle for information. Instead, what we use, and I'm going to show you, is we try to, on the spot, on the real time, to retrieve real information and put at the disposal of the large language model to use to provide the output. So the application, it's in a chat interface, and doctors can simply add some kind of straight questions like, what's the posology of amoxicillin? And it is kind of straight, I would say, straight question. But it also enables doctors to provide very complex clinical scenarios. And this is an example, is an example that, there's a lot of information about a given patient, signs and symptoms, some vital signs, some results of labs. And what is asking is what's the most likely diagnosis. So this is a very difficult problem. So what we're trying to do is using AI to, extract the key ideas of the prompt, go and search for, in our case, we search for academic articles, and we try to find, number one, the relevant articles that has a very close match with the question, and then in very, very high speed to try in those articles to find and extract the pieces of information that matches the user questions and bring it on. And here, for this case, for example, we don't provide only one diagnosis. We try to provide at least three most likely causes. We try to, as much as is possible, extract from these articles what are the supporting evidence to present those three hypotheses as most likely. Additional tests to confirm. So, tips for the doctors to either ask the patient or do something else to confirm or rule out some of these hypotheses. And at the end, what is very important, we provide those reference, those articles that we just researched. Number one, we try to provide the reference in text. So I don't know if you are able to see, but between brackets, you see here numbers like 2 and 3 and 4 and 5. And here at the end, we provide, we relate those numbers with the sources. And this is very important because doctors can see where this information came from. And if they click there on the links, they can, the application drive them through the original article. So this is something that it's one of our key differentiators. It has made a huge impact here in providing more confidence to the doctors. Now delve into how we do that. I think there's a lot of AI practitioners here in the audience. I think the way we build these engines is through RAG. And RAG has this picture that illustrates very quickly that RAG, nevertheless, you have like a searcher that goes to a database to search the documents and provide to the LLM to provide the response. However, as we evolved, we start like very simple RAG, but as we go along, we face some challenges. Some of the challenges is how you find the relevant documents very, very quickly that matches the user's query. It's not easy sometimes. How to extract the piece of text in the document that match the query. That's also a challenge. And this I categorize as a reasoning problem. The first one was more like an information retrieval problem. The second one is a reasoning problem. And the third one is how, after you have all of these pieces of documents, how you compose those pieces together, citing the sources. It's also a reasoning problem. And what we see in addition to that, is the issue of reproducibility and repeatability. As you know, if you ask the same questions several times, the response of the generative AI will be different, and that can be a little bit not good. It can give a not very good experience, but this is how the stage of generative AI is as of today. So in order to tackle some of the challenge that I talk, we're evolving our architecture to try to divide and conquer. So we are dividing the subtasks, and here probably you all know, but this is the name that we do today. We divide them in agents, which is nothing there as small let's say units that encapsulates specific narrows and focus tasks. They have a LLM. Sometimes they have LLM, sometimes they have not. Sometimes it's just like a piece of code. But most of the times they can use a LLM to make decisions, to reason in that specific tasks. And that has an opportunity to us to use different AI strategies, because not depending on the tasks, we can curate different LLMs. For simple tasks, we can use like lighter versions of LLM. We can use different retrieval strategies. But all in all, the efficiency of the whole systems depends still on smart software engineering, our ability to, use, let's say, a concurrent parallel paradigms in software engineering to have the final output in the smallest latency as possible. And this is an attempt to provide more control of the outcome. As I said, the problem of R&R, repeatability and reproducibility, here we can control a little bit more, not 100%, but we can have agents that can sort more or less control the levels of hallucinations. If they're not happy, we can start all over again the process. But as much as we work on that, I think what we haven't seen that using only GenAI is limited. We always rely on, even in those small agents, in the decision making of the LLM. Okay, and we know that this decision is opaque. It's still black boxes, and it still have this problem of repeatability and reproducibility. So what are the current areas of research that we are doing in order to evolve and tackle some of the challenges? Is through the use of other forms of AI. As we spoke about generative AI, this is a more, let's say, hyped one that we're talking about today. But we have other forms of AI, the more traditional ones, especially the symbolic one, those which relies on ontologies, taxonomies, and logic. So one of the things that we're trying to do is in conjunction with what we have done so far, is to apply, let's say here, a pipeline like that, which is we provide in the same examples, we try to extract the concepts from the prompt. We try to categorize those concepts in taxonomies using ontologies and like concepts like the symptoms, like the vitals, lab findings, and etc. And after we have like isolated those concepts, we try to use some sort of a knowledge graph that have all those concepts linked to make sense of it. And here, one of the things that we try is to start from symptoms and go all the way through to disorders, to diseases. It's not always easy, and this is something that we're still working on, because to navigate and to traverse these ontologies is not always easy. Some ontologies are not, let's say, thought to be used in a user case like ours. So there's a lot of paths that sometimes ends up in a dead end. So we need to understand very well those knowledge graphs, and also sometimes most of the times, we need to expand these knowledge graphs and provide our own data augmentation. Okay. Well, so this is our current way. I mean, the way we're tackling responsible AI by providing data that is trustworthy and transparent. I think luckily I could have you a good idea how we evolved from using only generative AI, RAG, and now incorporating other ways of AI. Nevertheless, we face other additional consideration when it comes to responsible AI, and this is the thing that we are hearing from our, let's say, users. The first one is the problem of interoperability. A clinical decision support system shines when it has been integrated to, let's say, electronic health record systems, that the ones that have in big hospitals and clinics. Because of not only because it makes the workflow more streamlined, but also the data are more, let's say, readily available and provides to the doctor much more like let's say justification for using the CDSS on the spot. However, you're dealing with real patient data, so you have this concern of data privacy. How you transfer data from the electronic health records to the LLM, to an application like ours, without exposing patient's name and sensitive data. There's also concerns from the hospital owners about how the LLM that are embedded in application like ours will use this data. Are they going to use this data to train future versions of LLM? So this is a big discussion that we have, and we need to, talk to vendors and also have ways to attack to contain this problem, and also regulatory compliance. You know that we are healthcare is a very regulated industry. Sometimes the regulator enforces that you run all the let's say the processing inside your country, and most of the clouds and LLM providers such as Anthropic and OpenAI, they are elsewhere. They are not at least in Brazil. Okay, so this is the additional considerations that we are working on. We are being able to contain some of these case by case using, let's say, applications that anonymized information before inference. We are also thinking about using open source LLMs and instance the inference in a on premise, things like that. Okay. So I'm just finishing now. I mean, hopefully, you were able to have the idea of the application, the additional considerations, and I think the takeaways is that there's a lot of advances that the Gen AI brought to us. More specifically, the ability to interface with a human through a natural language. However, we need to acknowledge that this technology are in early stages today. It's not 100% reliable yet. In order to tackle that, in addition to use and mix and match LLMs, it still requires a huge amount of intelligence in software engineering to take more control, and using agentic workflow is one example of that. We still need to integrate with other forms of AI, most likely symbolic, semantic web, and other forms. We need to carefully roll out in production using safeguards, making sure we have human in the loop. This is something that I didn't talk too much, but I cannot stress that everything that we provide for doctors. We don't provide for patients. Why? Because doctors, they have the ability to critique the information, that they have the ability to make the decisions, the ultimate decisions. So it reduces a little bit the risks. But just to finish, there's a lot of much work to be done in data privacy and data exposure. Okay, so yeah, thank you very much, and now I open to questions.
Thank you, Roberto, for the exciting presentation. It seems very much relevant to some of the work that I do. A bit of work that I'm involved in the context of attribution and everything. So let's see if we have any questions from the audience or from the stage. Okay, so there's one question on what are some of the commercialization strategies for the responsible AI.
Okay, I mean, I can't speak more specifically about IntelliDoctor, because this is an example that we launch as business initially aimed to doctors, and they are our users, of course. They are the ones who use it, but and we're trying to launch as a SaaS in the beginning. However, we note that this strategy didn't provide too much traction, and most of the explanation are cultural aspects. The doctor is not used to subscribe to things like that. He most of the times he has a lot of resources that the hospital that he works at provides to him. So our commercialization strategy goes today more towards B2B. So our clients today are clinics and hospitals, and now the pharma industry. And the way we do it is through pure, let's say, customization and addressing some of the concerns that we talked about. So, I mean, to implement this, integrating with their electronic health records. This is one of the things that we provide, this integration. The second one, we try to provide them, tackle some of the issues of data privacy and exposure in terms of, having safeguards, having mechanisms to anonymize the data, to training doctors, and so on. And and some of them even go an extra mile, which is trying to contain the LLM inference by providing a more, let's say, in-house, in-country instance of the application that doesn't go elsewhere, and etc. So, and in the commercialization strategies, of course, this is the way we have done today. It's we every LLM, the cost drive is the token consumption. So we're trying to use the same logic to charge our clients.
I see. Okay, fantastic. So Roberto, some few questions from my side was that do you think that there is a scope for keeping faith with responsible AI while turning the system into a conversational system? Or do you think with the conversational system, like right now we are delivering outcomes in terms of, let's say, identifying the causes of a disease or the symptoms and talking about those, can we move this into a conversational space and still achieve responsible AI? Or do you think that that's still a long shot?
I mean, the way we deliver today is through conversational, and the interface in conversation has advantage and disadvantage. The advantage is that it's open. I mean, the doctor can ask every question, which is good, which is he can put more context. But the downside is because it's also open. And for the LLM, depending on the way he framed the question and depending the way he put sensitive information in the prompt, makes our lives very, very difficult. So one of the things that we're trying to do is when we have in a very high risk setting, let's say when we are having integration with hospitals, some of the applications we're trying to move from the conversational to have a more, let's say, assertive interface with a very, very narrow, input information and very, very assertive output.
Okay. And one more follow-up question, Roberto, is that when you were looking at that attribution, right, where you just don't want to give an outcome, but you want to attribute it by the relevant scientific articles, right? Did you fall into this situation where the model generated something that doesn't exist, or the citations that are cooked up, for instance, or created, or did you control that by restricting the search space?
No, of course. In the beginning, that was a big challenge.
Yeah.
And for me, what is let's say the variable controls that move the needle? The first one is a good prompt engineering. So a good prompt engineering, it's effective, but effective until a certain way. Then the second thing that moves the needle is the robustness of the large language model that we use. So in the beginning, I mean, we let's say the GPT-4 Turbo, it was very, very good. However, it was very, very expensive. When we moved to GPT-4o, we noticed that the performance felt a little bit. And the third one, it's now moving to agentic workflow where we have agents to check whether the result so far has really been done through the content that was provided, and another one to check if the in-text reference it's okay. So it's like an evolution.
I see. Okay. I think
But
we are.
We are not 100% there. There are still cases that we try to understand and figure out what has happened wrongly.
And do you think that the knowledge graph has a role to play in this scenario? Let's say, for example, if you have a PubMed knowledge graph, it would have been better to do. The attribution would have been more tighter and more controlled, and the models can be, let's say, can be smaller, and knowledge graph can be bigger and things of that nature, right?
Yes, that's what we are. That's why we're looking into that area right now.
I see. Okay.
Well,
Okay.
let's save some of these questions for the panel discussion. I see that we're getting the juices flowing. Manas, Roberto, thank you very much. We're going to take a.
Thank you, Manas, for the moderation. Excellent.
Thank you so much.
We're going to take a brief intermission, and then we're going to be back with the next presentation, after which we're going to have a panel discussion, and Roberto and Manas will be there. So we'll talk to you soon.
Thank you, Joaquin. See you.